So, good afternoon to all of you, and welcome to session 3. I hope you all enjoyed your meal. I would like to request Honorable Chair, Co-Chair, and our keynote speakers to kindly come on the dais and take their seat. Dr. Subhash Salunke, Dr. Katya Polman, Dr. Freddy Sanguba, Professor Guy Kegels, Professor Venkatraman, Professor Melissa Parker. Thank you. I'd like to remind that we have put some feedback forms on your tables, and we would really appreciate if you could leave your comments and some feedback at the end of the session. Thank you. With that, let me take a pleasure to introduce Dr. Subhash Salunke, just left to the center, who is going to chair this session today. Dr. Salunke graduated as a medical doctor, and he did his post-graduation in community health. He subsequently did teaching at medical college and guided postgraduate students. He then joined health services in state of Maharashtra, a western state in India, as a deputy director, and he worked over the time and rose up to become Director General of Health Services in Maharashtra. During this time, he also contributed significantly in the development and overseeing of National AIDS Control Program, particularly the phase 2 of the National AIDS Control Program. And during that period, he worked with National AIDS Control Organization and World Bank. After his tenure in the health services, he joined the World Health Organization Southeast Asia Regional Office as a regional advisor. He also worked as a country representative to Indonesia, and he retired from WHO as Assistant Regional Director. He currently works with Public Health Foundation of India as a Senior Advisor on Health Systems. He also has an additional charge of being Director at the Indian Institute of Public Health in Bhubaneswar in the state of Orissa. He also oversees all the training activities of Public Health Foundation of India. So thank you, Dr. Salunke, for agreeing to chair the session. I would also like to introduce Dr. Katya Polman on the right of the center, who is going to co-chair today's session. Dr. Katya Polman is an epidemiologist, and she heads a unit of medical helminthology at the Institute of Tropical Medicine Antwerp in Belgium. She also teaches as an associate professor at the Free University Amsterdam, Netherlands, in the area of infectious diseases. She has university training in medical biology and parasitology, and she did her master's in epidemiology. She did her doctorate on the topic of epidemiological application on circulating antigen detection in schistosomiasis. Her current field of research are in epidemiology, transmission dynamics, and control of helminth infections. So thank you, Dr. Polman, to agreeing to co-chair the session. And with that brief introduction, I would leave the floor to today's co-chair and co-chair for the further proceeding of the session. Thank you.
Thank you. Good afternoon, friends. It's always difficult to deal with postprandial sessions. With wonderful meals and then good environment, you tend to find that the difficult to concentrate. So with this particular background, I am sure you will appreciate the fact that the sessions will become more interesting, and I will be requesting the presenters that this particular situation needs to be taken into consideration, that you are fighting against the odds, and ensure that these presentations are really, I won't say entertaining, but informative, and also to ensure that the audience feels that this is going to get a lot of input, a lot of information, and the knowledge out of that. We will be, what we are planning today is there are actually 4 keynote speakers for today afternoon, and there will be 2 paper presentation, oral presentations. We plan and we request the keynote presenters that about 30 minutes for each presentation is the time limit that we would like to keep it for ourselves. Out of that, around 20 to 25 minutes for presentation and 5 to 10 minutes, depending upon the response from the audience, we would like to have discussion at the end of each presentation. And thus, what we propose to do is to ensure that we want to finish at the whatever time that is, that by 5 p.m. In between, we would like to have the tea break also for 15 minutes. So this is in nutshell the kind of the plan that I have, subject to the approval from my co-chair and also from the colleagues here. Is it okay? Is this okay? Acceptable to you? Thank you very much. Well, friends, since morning we have had a wonderful presentation, and I must compliment Dr. Devadasan and his team for giving us an opportunity to listen to Dr. Jacob John. The way he has made the presentation today morning, he has set the ball into motion, and he has really pointed out and brought out some of those very important issues that we have to take into consideration, whether we are talking about the neglected diseases or we are talking about any other public health issue. The issues that he has focused, the points that he has made, and the fact that irrespective whether we are discussing about India or within India about the states, as all of you are aware, that in India each state is sometimes bigger than some of the countries, and that's the reason, and they are so variable in their all sorts of, including the public health problems and the issues. So under the circumstances, when we are going to discuss today afternoon, particularly about the health systems and the neglected diseases based upon planning and evaluation perspective for these diseases, and there will be these presentations. My dear friends, let me also assure you, with limited experience that I have, that the perception of the term health system is quite different. I have seen, I have witnessed, and I have experienced that people's perception about this term health system is quite variable, and that also have to be kept into mind. According to me, I feel that the point that Dr. Jacob John made it, that ultimately health, public health is the responsibility of the concerned government. What we have to do, disease control is the responsibility of the, whether it's a state government or national government. In India's perspective, because we are a federal country and because the state, the health is a state subject. What is meant by that is that the states have the responsibility and the authority within the framework of the guidelines issued under the national program by Government of India, and we follow that. Means the state governments are expected to follow that. But there is tremendous amount of freedom and flexibility to the states if they so desire. That we have to also keep in mind. As far as the neglected diseases are concerned, why they are neglected, why they are called as a neglected disease, Dr. John has brought it out. I personally feel that these neglected diseases, and out of all other criteria and components, I feel the fact that these are the diseases of the poverty is the basic reason why we are neglecting them, or why we have neglected them, and why the chances of their neglect is likely to continue, because none of the politicians suffer from this unless they make all-out efforts to acquire them. Otherwise, these diseases are acquired, or the poor people are exposed to these, and that is not the priority, in spite of the fact that whatever the policy makers at the national and state level may say. However, that is not reflected in the policy, nor it is reflected into the resources. So under the circumstances, with this and with the factual position that exists today, not only in India, as I have worked at the Southeast Asia Regional Office, I have also worked and seen the kind of national programs being designed, planned and implemented in 11 countries. At least I know about 11 countries fairly well. So I feel this reality we have to keep it in mind. And with this fact, Now we are going to discuss about the relevance as far as these 3 or 4 presenters are going to bring out some of those issues, and I am sure some of these issues will be provocative, thought-provoking, and we will try and discuss them and come out with some suggestions, hoping that ultimately Dr. Deva and his team will reduce them in writing and share it with the concerned people, concerned agencies, including government. Hopefully it will have some impact. With these words, now may I request my co-chair, Dr. I'm scared to ensure that I pronounce her name properly. So, Dr. Poman, that's right?
Katia.
Dr. Katia Poman, to now take it further. Thank you.
Okay, I would like to, does it work?
Yeah, it's right.
Invite the first keynote speaker, Professor Freddy Goba, sorry. Professor Freddy Sengoba, he is an associate professor in health policy and system management at Makerere University, Kampala, Uganda. He graduated as a medical doctor from Makerere University, did his MPH from the same university. He was awarded his PhD from the London University. His research focuses on health system management with areas like health workforce, health financing, governance, post-conflict health systems, etc. He's a member of the governing board of Health System Global, which is a society for health system research. The title of his talk is Discomforting Science, ? Randomized Experiments and Health Systems Evidence to Guide Disease Control. Looking forward to your presentation.
Okay, thanks for the kind remarks, and good afternoon. We are required to do some acting so that you keep awake, but I'm sure the title is enough contribution for me to make sure you have the energy. As said, I'm actually here to talk about how, as scientists, we generate evidence that can guide the practitioners as well as policymakers in terms of public health programs, including disease control. In this presentation, I'm concerned about the evidence and its methods. In particular, I'm concerned about the evidence to enable public health programs to leverage both upstream and downstream actions that support disease control. When I say upstream, we've heard from the chair talking about the role of governments. We also heard in the morning a lot of downstream programming and the challenges around that. But how do we bridge these 2 levels? How do we ensure that when we say program X is effective, and that is usually coming from research from downstream focus, how do we understand the systems that support that downstream effectiveness to actually accrue? It requires us to look both up and down, and many times, and this I've come to this presentation from a background that is looking at many public health programs being evaluated with rigorous methods, most of them randomized trials. But when I read them to try and find out what we should actually take to policymakers or to practitioners, I don't find anything useful. It actually starts another research program to understand what was this intervention, how was it implemented. They say it was controlled, but exactly how was it controlled in health systems and public health? There is a big challenge about what we mean by control. We work with people, with agencies, with collaborations, and this word control sometimes doesn't make sense. So how can we be more transparent and understand what actually we are talking about when we say intervention X achieved X kind of effectiveness? This morning we heard from many programs that are attempting to address disease control in complex health systems. We also heard about the challenges that they are facing, especially in implementation. The last statement I want to quote is from Professor Jacob Jones. When he was answering the last question, he said that in theory we know what it takes, what needs to be done, but in practice we do not know how to put things together faster. Meaning that we have a science that gives us what we know, but the science is devoid of how to. And that's where I want to dwell. In Nepal, again, we had our clinicians, when given or faced the task of trying to address this persistent fever syndrome, the main findings were they were even beginning to question their capacity. It is not diagnosis. I even don't understand this. I never heard about it. So when we come up with a strategy that has helped to control a disease based on this persistent fever syndrome, how can we tell what the system required to actually fix it? What did the clinician have to do from day one to make this program work? And these are challenges that are central to what I'm going to talk to. So the key messages are here. Generally, there is a need to improve the instrumental purpose of public health evidence to guide practice. To evaluation of single initiative for effect size may be failing to capture those multiple contributions that come from the broader system. We also need public health interventions that tend to be implemented without pre-trial development. Means we try to say 5 things are important, and we just go and try to do them. But how these together come up to be effective and what degrees within this package that is effective is something that we need to be careful about. And of course, we really needed to add to the randomization approach to generating evidence so that we can understand the effect size. What I'm talking has come out of some work we've done with colleagues and published in PLOS Medicine, so you can find them. But generally, this presentation is also asking us to be able to move across the broad spectrum of science, not just being on one side, which is positivistic, where we can tell that this effect has been arrived at, or this regression gives us these factors with these coefficients, but try to understand how do those coefficients actually arise. What are the nitty-gritties, and what are the realities, and what are the contribution of context, and what are the contribution of other variables, especially upstream, that are important. So public health programs tend to have multiple dimensions. Of course, we are looking at vertical, horizontal, and diagonal, and I won't go in that because there is a talk around that, if not today, tomorrow. But the important thing is that there are interdependencies that we require to make programs work. Several institutions have to come together, work teams, individuals, materials, and there are a lot of dynamics in all this. We are not dealing with a steady state that once things are assembled, it's like you put a truck on the road, once assembled, it runs. These things keep changing. There are so many dynamics in them. Today they are working, tomorrow something happens and they don't work as well. And there's a lot of collaboration that need to be coming together. That's why I put in that picture, which comes out of the research I'm doing in one of the districts in Uganda, trying to understand the network of agencies that are trying to work together to implement HIV programs. And by comparing this with other programs, I can tell how the resource of institutions, for example, is coming together for particular programs and where are the inequalities. Of course, the randomization problem that I'm trying to address here has a number of things. One, it assumes, or at least it is the highest level of evidence as we know it from our epidemiological training. But one of the challenges that it has for especially those of us who are trying to understand how to implement programs and how to get these interventions work is the problem of blindedness that it does bring about. We know why blindedness is there. Usually want to randomize so that we account for those things that are not in the data. But somehow we do wipe out the things we want to understand. Part of it is context. If it works very well here in this state, will it work in another state that may have a very different context? And of course, we also wipe out tactical information, which is important for replication and scale-up. So these are, I think, the challenges that need to be addressed. So I'm going to talk quickly through 3 of them. One, trying to understand these programs not as simple programs that have a simple causal path where X leads to Y, but rather complex interventions that require that many things come together. The second one is the issue of variability. How do we understand these programs? When we say, for example, that in this state, we've been able to bring down a program, a disease to a certain level, and we document the intervention and give trends. Exactly can another state be able to achieve the same results with the same strategy? what exactly do we need to understand there? So I want to invite you to understand context and theorizing around them so that we are able to understand whether the same results are likely or not likely in different environments. And of course, the issue of implementation. Implementation is not something that we in public health can assume it is going to be standard, although we write lots of books of how to standardize this implementation, but the actual process of management and management science is making decisions as we learn. And if you are going to invite learning into what we do, and therefore making decisions, you're already admitting to the fact that there can't be a standard implementation. There are going to be decisions made and variation in them, and therefore we really needed to go into a bit of social science to understand the ethnography of implementation. I'm glad that someone is going to talk about after this session or during this session about the issue of social science in public health. So the first issue of causal path. In general, this can be investigated clearly when we go to downstream. Downstream is sometimes what I call core phase. So if we want to understand whether doing an integrated disease surveillance works, we run to clinics. And of course, in there we are using the workers to try to understand the diagnosis they are getting and try to follow up in the communities. So if it works there, of course, we run and write papers. It has worked, this intervention. But how does this intervention really tap into already existing capacity upstream? How does it tap into the existing infrastructure about information, the capacity of the group of people that are already in the system, and what are those preconditions that are necessary to ensure that downstream interventions work? So sometimes the too much focus on the front line and doing a lot of research there deprive us of understanding what are the upstream issues that do support what we document. And so I think I've already talked about these, but what randomization studies take us to believe is that we should really be interested in systematicness in how we collect information. These days, all my students are wanting to do systematic reviews, and when they do systematic reviews, they throw away all that is not randomized, and they end up with 1 or 2 studies done in the US that has nothing to do with Uganda. So in the end, I ask them, so what is the value of what you've done? Yes, you've read a little bit about it, but in the end, you can't help our community. Yes, you've learned how to do a systematic review, but what value is it to what we are trying to do here in Uganda or here in India? And I think these are challenges that we really need to be able to interface. So when I talk about systems, I want to first define them as complex network of interrelationships within agencies, facilities, and providers within a zone, but also that if we are interested in building capacity or strengthening systems, we really need to be looking at the patterns of relationships that arise out of this instead of just looking at effect size. So we definitely look at relationships that help us to get those results. And systems thinking has a couple of things that is brought up. I think it depends on whether you want to think about health systems as anatomy or as physiology. Some people say if it is complex, break it up into pieces and study the pieces, because that way then you can understand what's going on. But when I was in medical school, the first thing they taught us was that, well, you need to understand the bones and muscles and how they hold each other and they enable movement. But then you also needed to go into the physiology and understand the hormones and all these nerve reactions, things which can actually make the anatomy move are not necessarily in the anatomy, it's in the physiology. And I think I want to equate systems here, trying to look at physiology, trying to understand how do various relationships make us to achieve targets or goals in health systems. And this, it's important that we understand them as integrated whole and not cut them into pieces, because then it becomes difficult to put them back. Now, when you look at what drives performance in health systems, I've tried to bring here a complex picture that is about if we are interested, let's say, in trying to control a disease, we are looking at surveillance and services downstream, which is probably going to come from a certain work team within an organization like a hospital. Hospital is going to be within a district kind of setting, Oh no, I think the organizational system around the hospital. We also have district, some places it's region, and then you have a country, a national level. You may even have a global level. Now all these come together to what we see downstream. If, use the example of this morning, if you get the drug donations for a control program coming from a global pharmaceutical company, let's say in the US or Europe, it may actually affect very much what you do here. In Uganda, we had an unfortunate situation of annoying some of these donors. So they choose not to send the medicines for malaria. So however much you try to understand the system down here, why malaria is not going, you actually need to understand the donor and why he got annoyed before you understand this. So and you have to have the whole levels of that support this system to be able to understand what you see downstream. We can say, oh, these workers are not doing this or not doing that, but sometimes the essential ingredient is not anywhere close. And so we really need to have an up and down way to understand. If you're trying to add an intervention downstream that is trying to, let's say, pay for performance, if the performance is surveillance, how can that be replicated? And I did a study some time back trying to look at performance-based financing, trying to put incentives downstream. And these are also complex. You're trying to set targets, you're trying to audit performance, you're trying to give feedback, you're trying to give rewards. You need to finance this, you need technical assistance for that. By the time this innovation is evaluated to say performance-based worked, it is about 8 or 7 different ingredients. Which of them worked? It may not be very clear. So tomorrow, what a policymaker will write in a guideline, will it be that performance-based financing works 70%? Will that give us value? No. We really need to understand how was the reward done, who audited, how was the auditing, where was the capacity for that, how was feedback, how did feedback lead to action? So in general, we really needed to be able to unpack a lot of evidence. The second, and quickly, when we look at innovation, sometimes people write as if they are planting mature trees, and I like hotels and people who design venues. They can bring a mature tree and put it there, and people who come, they find it beautiful. But in development, we are not bringing mature trees to plant. In other words, we're not bringing mature programs to communities. We're actually trying to get these programs from start to the point that they are actually able to deliver. But within a year or two, there's papers out, this worked, this didn't work. Before even the program has achieved enough capacity, there's already a lot of evidence floating around. And so we ask, did really this program go through any kind of maturation? How did that mean? And what implication does it have? And I'll skip this and take you to this slide. I work sometimes in situations that have health systems under stress. And Uganda, we have some part which is being under conflict, and we are trying to understand what is going on. So in that, if you're trying to understand how that system there can deliver care, it's important to understand on which phase it is in terms of its capacity. This is an area that went through conflict, everything got destroyed, and now it's coming back up. So if you did the study during the time that the system was under stress and was getting destroyed, maybe any intervention you bring here, you'll conclude doesn't work because everything was going down. Whether you are calling it disease control or utilization, everything will go down. If you come down when it is like sustained failure, nothing works, the evidence will conclude. If you put your study around here, you might get 70, 80% effect size because everything is going back up. Whatever little you do, it can only go up. When you find it here, you may say, well, there is very little effectiveness. Whatever you put in, you get a little bit more. In other words, trying to understand where the system is sometimes does help us to understand our evidence more. And there is a lot of studies. I work a lot on financing aspects other than disease control, but there are studies that tell us how many things are happening around here because there's a lot of donors, grants coming in to help the system to work. But somehow they tell us that, they don't tell us that there is this curve, so we don't know, we assume that it's always going to work like that. If we go into mature health system and they are already on this flat phase, the evidence doesn't seem to be replicated. I have 2 minutes, so I will summarize. And of course, the issue of theorizing about, let's say, surveillance. We also know that if we are planting seedlings and non-mature trees, they are going to be early capacity building, they are going to be a learning phase, and they are going to be a competency phase. And this is important for surveillance because what the data you will get when you are just starting to build is going to be very different. And here is going to be different, and there. So if surveillance is a measuring tool, like when you're buying sugar, it's going to be measuring a kilo of sugar differently at this level, at mid-level, and that level. So many times what we even have documented as growth or lack of it is actually the capacity of the implementation, not so much the capacity of what the implementation is able to do in terms of service delivery or control. So lastly, and quickly, implementation fidelity. As I already said, there are lots of changes that are happening around implementation. When we do use or invoke randomization, we assume that the program does not change. Ideally, it should be the same from start to end. But we know that there are a lot of decisions that are being made, there are a lot of changes that are happening over the implementation phase. And this does imply that actually implementation capacity is never the same throughout. Just to entertain you with a small graph, when I did a study around performance-based financing. In general, the assumption was you give a bonus and performance will come. But as you can see, over time, there is various intervention. They have to select the service that they are going to do. They have to be audited. Feedback is there, reward is there. And once the reward is given, it goes through another processing. It goes through criteria for fairness and trust, how it is allocated, how individuals get or rewards either as individuals, teams, or as organization, and subsequently decide whether that bonus works or didn't work. So in summary, I want to invite us to be looking at ways to understand complex systems through methods that allow us to understand complex systems. And there's a theory I want you to get interested in. I won't go in detail because my time is running out. But generally, there are ways we can study health systems by trying to go beyond the comfort zone of wiping out the things we want to learn. Thank you very much.
Thank you very much, Dr. Senguba, for a very stimulating and complex presentation. So I feel some of the messages which are very clear is that for developing any health systems capacity, adequate time needs to be definitely involved or need to be given. Similarly, we have to also take into account that these are the issues, so those who are the policy makers, planners, we have to also consider the complexity of these issues. With this, can I have a light little more, because I think it has become really difficult. So the now topic is open. If there are any clarifications that you would like to seek or points you want to make, can we have more light? Yeah, slightly brighter light. Yeah, okay, thank you. Yes, any question, query, clarification, suggestions, inputs? Yes, please, Dr. Deva.
Thank you very much, Professor Sengoba, for this very interesting presentation. I learned a couple of new things as part of your presentation. But I'm asking a very practical question. We usually, as an academic institute, we are working, and then suddenly a policymaker comes up and says, you know, I want a solution for this, or will this work, or has this worked? Or do some research and in 6 months tell me whether it works or not. But I understand where you're coming from, but I think many of us as academicians, this is a situation that we are in. So what would your advice be in such a situation?
Thank you.
Yeah, you can use this. Yeah.
Okay, it's a good question. Actually, I spend much of my time trying not to be in my office an academic, but working with the people in the Ministry of Health and other relevant agencies, asking these questions. But what I've learned is they rarely ask what works without a need to understand how it works and how they can implement it in their place. Otherwise, that becomes a question that academicians we ask. We want to understand where it works because we don't have maybe legitimate obligations to see it work. So most times, at least where I work, they come with two questions. What works and how does it work? So that the second part is the one that actually helps them to understand what they need to do, trying to get that science or evidence into their own context and change their social realities. So I would say that both questions are important. But I think the point I was trying to labor across is that as scientists, we really also need to put value on the second question.
Okay, any other question? Deva, in continuation to what you were trying to find out, I narrate what I have to respond to some of the colleagues who used to come from, when I was at DG Maharashtra, the 35 district health officers and civil surgeons used to attend the meetings, and when there used to be presentations that we wanted from the complex issues to be given, my request always used to be to those people who were coming either from World Bank, WHO, or others, or institutions, that consider that we, sitting, those who are part of the implementers, are going to be translating this message down to the field level, like say A&M, which is the most peripheral level. How do we put this across in such a way that it will be, one, appreciated, understood, and it has relevance to their day-to-day working? That is how all these issues need to be taken and then converted in such a fashion that the people in the system, and I'm coming back to the point, as I say that when I'm saying system, right now we are restricting in a very, you can say, a health system has the definition, as has been already indicated, can be much broader. But even if we were to consider the health services being provided by the public sector, say government, how do we ensure that all the players in this are on the same page and they understood that particular message? So that itself is a challenge. And I think that challenge, if we do not address it, then what happens, there is a or the distance between the people who conceive these policies and people who implement them. Thank you. Any question? Yes, please.
Thank you. No, it was a further reaction to Deva. Of course, on the one hand, you have the whole debate on what is knowledge and how much uncertainty can we tolerate. But what I felt in this question was also the anxiety for survival. This politician comes and he wants an answer, and my survival depends on that answer. What should I do? I think that as an academic institution, you should dare say, no, this is impossible. I will not do it, and I will not provide you with an answer because it will not be useful or not be valid in 6 months' time.
Fair enough. I mean, that's a kind of an advice that you can think about it. But with a little bit of humility, I can say that sometimes it becomes extremely difficult to put it across in such a way that it satisfies both the parties, which seems to be many times difficult. Anyway, any more question, queries? Yes, please.
I know time is running out for the discussion on your presentation, Professor Sengoba, but could you shed some light on how to respond the how question that the policymaker asks you what works and how does it work? How to approach as research the how question? How do we answer the how question?
Yes, it's a good question. Actually, if it has come a bit earlier than my papers refused to come out of the journal. But I will say that there are actually ways to understand the how question. In general, it requires us to be a bit more focused on what it actually takes, the people on the ground at various levels. When I say people on the ground, we may all think it's just downstream. But what does it take for the teams on the ground that are implementing this to actually do what they are required to do to address? But also, what do they need for the activities to succeed? And how is that flowing downstream? It is not as easy as doing a randomized study where you kind of are comfortable not to understand this, because you really need to invest a bit of time. And the study that I did was following a big pilot in about 25 districts. But what I did is to constantly be part and parcel of what was taking place. For 3 years, going with the program for all essential activities, but also falling back after essential activity to understand how do the players on the ground feel about what they are doing, the support they need, and talking to those that are providing support to understand what it is that they are finding either as enablers or barriers to be able to support the program, what collaborations are coming on board. So it requires asking several questions, but also being guided with enough theory of what you think would be useful to understand upstream, but also downstream. But as I said, something will be coming your way soon.
Thank you. Any more? We still have a few minutes. Please.
Sir, I just wanted to ask you, when we do studies or evaluations of a certain kind of program, generally in epidemiology we measure everything, and that's how we state our results, and that's why we have trials, and everything is measured out. Now in terms of issues related to context, what happens when you cannot measure them? I think that's the difficulty. How do you answer the how? I think my question just kind of follows up on that. How do you measure things like motivation of the healthcare workers, the environment in which they're working, their workload? These are the contextual factors that we normally encounter, and everybody knows the general situation. It's not like the government or the authorities don't know about these problems. But in a study where you've measured something, how do you also, as well as possible, can you measure context to really add, scientific credibility? Because in science we want to measure everything, right? And that's how we state our facts. So could you throw some light on methodology in this aspect?
You used the word measurement, and I think certain things are not measurable, yet they could be more important than the things we measure. I think this is the issue to try to understand. I prefer to use that, although it is also not measurable, to understand. But many times we actually want to understand what makes a program succeed. And yes, among those things, there will be those things that need to be measured. But also there will be things that we just need to understand by using non-measurable methods. So it's a core really to embrace methods that enable us to achieve that understanding. And I must say, even in my training, I was more exposed to epidemiology, but with the time I have learned to complement epidemiology with more other scientific domains, especially qualitative understanding of what happens. And try, because it is, if I wake up as a health worker to do certain thing, what actually is going to drive me and maybe the collective of us to succeed in the program finally to show results is what I have taken as important. And unless we find ways of getting that, whether we call it motivation or call it other incentives or whatever it is that understanding of that is important. But also we know that certain contexts are not likely to be able to drive the program. And it is possible to even understand that this is a hospitable place. If you put this program in this kind of context, it will work. But this context is really hostile. Even if we put the program there, we know it's not going to work. And I think it doesn't take, I think science has a lot of tools for us to tell that this is hospitable and this is hostile. May not be measured.
Thank you. Any other question? If not, yeah, please.
So I'm from Cambodia. My name is Song. There's we have some kind of observation especially on the vertical program that have been implemented in the country. And the same model apply, you already mentioned it should be on, depend on the context. But on the upstream part, it's very difficult to measure at some point, because the same model apply in different contexts, or the same context, but the output or the outcome of the program are differently. And people usually mention this a strong political commitment. And a strong political commitment sometimes depend on the leadership of those, program or policymaker in those contexts or those areas as well. So it's some kind of challenging to measure at some point, because we found on the upstream part that you mentioned is how to measure or how to document the style of leadership which contribute to the program. Is there you have any clue, any idea how to measure that?
Yeah, measurement is quite a challenge. I think what I'm trying to say is that, yes, there are areas where measurement will be useful, but there are also ways to understand a system, or be it upstream. In there might be things that are not measurement, but they could be helpful. I tried to show a graph about collaborative interlinkages of agencies trying to implement HIV programs in a particular district. That is partly trying to say, let me try to map out who are the players and how they come together for this program. I'm creating some, not measurement, but visuals or way of understanding of this context. When I go to a place, another district, and I find there are about only 5, in another place there are about 105 agencies, already I can say the context here is that there are many players coming together to implement this program. In that place, only 5 are coming together. I'm starting to build a context about, I think here they might be successful if they are able to collaborate. Here, maybe they are just too few to achieve any impact. What I'm saying that, yes, we can use the word measurement, but I think we may be able to embrace a number of tools out there to try, including political science. The challenge with the public health practitioners, we only schooled in a small, narrow area of science. But I think we really needed to broaden our tools. Actually, these days, and the reason I'm on the Health Systems Global, which is a new society, is try to advocate for broadening the scientific lens that we actually do bring to public health, because we really needed to be working with political science and other domains of science where measurement may not be the main scientific tools to generate data, but they do actually drive society. That's why we have politicians making decisions, because there is a science out there about these things that we just needed to tap into.
Thank you. There is also science to the politics. Yes, yes. Last question, please. Yes.
Yeah, it was in fact not a question, but really to support what you just said, Dr. Sangoba. I'm Severin Theis from Institute of Tropical Medicine, an anthropologist, and I'm really reacting to those questions about measurements. Indeed, some behavior, some way, some culture facts are not measurable, and it's not the goal. I don't think that science is just numbers. If you come with words, it's also valuable and valid. And so there are some methods and there are sciences. I'm sorry to say that social sciences is not just to be beautiful, but we have tools, we have methods to follow. And so like focus group discussion, in-depth interviews, participative observation, and yeah, I just wanted to accentuate this point and that you don't need numbers and to know how many people are doing that and that, but to understand the why and the how they are doing that, there are some methods available.
I also wanted to thank her contribution. I think in general, I've learned that we in public health are slightly behind. I think what I always see, and if I allow me, Chair, it won't take a minute, I watch a lot of detective films, And the reason I like detectives is that actually they can hang a person based on non-measurable things. But in public health, we want to measure everything to about 95% chance, or reduce the chance of error to less than 5% before we make something. But in the other domain of science, the legal and the judiciary, they can hang somebody without any p-value. You should ask ourselves, what kind of science are they able to use to generate evidence to hang somebody? And in public health, we are trying to measure everything to avoid death. Anyway, just a reflection.
Thank you. Thank you very much. So, friends, now we'll go for second presentation. Dr. Bowman, please.
So we changed the program a little bit around. We have the second speaker is now the third, and the third will be the second. So now I would like to invite Professor Venkat Raman. He teaches at the Faculty of Management Studies, University of Delhi. He is a researcher and a field-level practitioner on exploring how public-private partnerships could help in improving access to healthcare services to the poor and marginalized communities. And the title of his talk will be Public-Private Interface in Disease Control Strategies.
Well, it's just the time ran out for the computer also, so it gives me an opportunity to perhaps talk a little extempore for the time being. They always say that never give a mic to a professor, and you have a double whammy, or rather triple whammy today, and the entire afternoon is with the professors around. So I hope beyond this session you would be able to keep your interest alive. First of all, let me thank IPH as well as ITM for bringing me here and sharing my thoughts about working together, or rather public-private partnership, which we normally call as. I'm not an economist, I'm not a clinician, I'm not bringing any particular study here, but way back in 2001, when World Bank published a report on India about health system or health sector in India, they said a lot of things about what happened, what's the status of private sector in India. They made statements like, or they brought out the data like 93% of hospitals and 80% of beds and 80% of doctors are in the private sector. A lot of us were very skeptical about it. We thought that this must be one of the ploy to bring in greater private sector into the health system. But we didn't have to really wait too long for the government of India to even admit that the private sector had actually mushroomed in this country, thanks to a number of innocuous policies that the government of India had brought out and recognizing health as an industry sector, which allowed the growth of private sector, and simultaneously the investment rollback on the public health system had made sure that the private sector grew phenomenally in India. There is a data which suggests that at the time of independence, we had just about 8% of health sector in India as private sector. And in 2005, what we see in several documents of the government of India is that the private sector had really become a monster, if you were to use that particular phrase from an activist point of view. So in after 2001, we were actually trying to find out whether there is, if the private sector is really such a huge one, is there something government is trying to do or trying to tap them in order to provide services to the public? Somewhere in 2003, we were helped by Dutch government to, with some funding to look for some of the PPP models in India, private sector initiatives, in order to reach the poor. So what I am trying to really talk today is in terms of what kind of models or initiatives or schemes that are there in Indian context, and then use that similar framework into the disease control program. My experience with the disease control program is limited. I have some role to play with both RNTCP, and I have had little exposure to HIV. So I am using this particular platform to kind of give that broad lessons of what we have known about private sector or public-private partnership in the last 10 years. That's what I bring on table today. Just to set the context here, if you look at this particular diagram, I'm sorry I'm not able to really bring in each one of them because something happened in the computer. If you look at the first diagram or first graph that you see on the left corner, that's the volume of patients going to the private sector in India for outpatient services. This is from the government source. On the second one on the right side at the top, this is the proportion of people in India who are seeking surgical care in the private sector. There you see some of the states which are very low because there are other reasons. You see the bottom one on the left side. We invariably thought that the private sector is predominant in the urban areas. Another government report says that a large proportion of diagnostic services are sought in the rural areas from the private sector. Diagnostics does not necessarily mean, both the outpatient as well as diagnostics does not mean only for, advanced curative services. This must be including for tuberculosis or HIV screening or anything of that sort. And the last one that you see is that the proportion of, or rather the variation in terms of how much people spend while seeking services from the private sector and while seeking services from the government. This sets the entire notion about what private sector is up to, or how much of the private sector service delivery is predominant in India and how expensive they are. This is the first position or first discourse or the first point I wanted to mention. Some of you may have seen this paper of mine last year. This was published in PLOS One. This is about tuberculosis. This is not in any remote part of India. This is in the center of Delhi. We tried to track 108 tuberculosis patients, trying to find out where did they go first as a port of call if they found some kind of symptoms of tuberculosis. You will see that the first one, which is green, and the red ones are the ones which are informal providers or quacks or pharmacists. They go round and round about before they finally reach dot center. By the time they reach dot center, it's about 3.5 months. And some people would like to say that they should have gone to the formal provider directly. Some of the formal providers whom you see in this graph as the blue one, they retain the patients for the longest period of time compared to the quacks and the informal providers, or the pharmacists. They treated the patients by their own till the patient exhausted of the money. And then they referred them finally to the dot center. So when we talk about private sector, it's not just about the allopathic patients or allopathic doctors or the formal sector hospitals. We are talking about a very large proportion of people in the informal providers. And that informal providers in the center of Delhi is so predominant that it actually gives you jitters. Now, we saw that a large proportion of patients go to the private sector. Who is paying for them? This is the diagram from the National Health Accounts. And what you see here is that a largest proportion of expenditure towards health services is paid out of pocket. One of the states which is considered to be the best state in terms of public health facilities, Kerala, has the highest out-of-pocket expenses. Quite a surprise. So, on the one side, you have a large proportion of patients going to the private sector. On the other side, you have a dwindling resources within the public health system. And then you are, the patients by nature would not like to go to any doctor rural areas we know they very well. I come from a village. Until you are not able to really stand up, you don't go to a hospital. When you go to a hospital and when you don't see the doctor or equipment functioning, You would rather go directly to a private hospital. That's the way that the private sector has been exploiting the patients. So, private sector is not that angel, all angels. They are actually having a huge trouble, and we'll talk about that, what is their one problem. We'll come to that little later too. But private sector in India is quite indispensable. You can neither roll it back, nor can, so far, till date, are unable to regulate them effectively. So in a kind of a situation where you are caught between deep sea and devil, is there alternatives for the government or for the health system to really do something about the patients? It's in this particular framework I'm focusing on, or my discourse on PPP falls into this particular framework. But several people have a lot of notions about what actually is PPP. For some people, it's just tendering. For some people, it's like that paraphrasing of an elephant and 5 blind men. Everyone wants to say something about what they perceive PPP is all about. But in a much simplified manner, you see that the notion of PPP is that somebody has to fund, somebody has to deliver the services. It's within this particular context. You see that the first cell is not going to vanish. Public hospitals are not going to be closed down tomorrow. Private hospitals are also not going to be closed down tomorrow. That's in the 4th cell. There are already, the yellow ones, a yellow cell that you see, there are already Gavis or BMGF and all kinds of initiatives that are globally going on. But what's possible and what could be explored further is the 2nd cell, where public financing and private sector delivery. For obvious reasons, why we say private sector delivery. Whether the word's obvious or is it only hypothesized is something that time will tell. Whether private sector is more efficient, has a greater access, could be regulated, etc. These are only time will tell, but we cannot really close our eyes and say that private sector cannot be tapped for their potential. As I said, that a lot of people have a lot more things to say about what constitutes private PPP. For some people, building hospitals through government funding is only PPP. In the sense, nothing else matters. Rest of them are all outsourcing, rest of them are all tendering. What constitutes PPP is that there is a risk sharing in building a tertiary care hospital. But for some, there are also management contracts, service delivery contracts, which could be PPP. Then you have a third possible group of people who say that let's protect the poor from the financial vulnerability and give them demand-side instruments, demand-side financing instruments. And there are people who would like to really have a much larger framework like social franchising or social marketing or even all kinds of private sector engagement as PPP. So it's not something that is very, very limited to only outsourcing is PPP. There is a lot more to really explore within the context of PPP. I've been very careful in using this word. There are possibly potential benefits. We still are searching for evidence about how much of these benefits are realities. So there are a lot of possibilities. Unless there is evidence to suggest that there are some efficiency gains or some excess gains, some equity gains, it's still a tentative process in which we will have to think about this. But at this particular stage, there are a lot of lessons to learn from what has happened in India. In India, we have plenty of schemes or initiatives and pilots and projects, etc., which are of health service delivery nature. I'm not getting into those, but I'm now shifting the direction slightly towards disease control programs. There are global evidence to indicate that engaging the private sector actually improves program effectiveness. I don't have to really, all of you are familiar with lots of documents that are our empirical evidence that supports that the private sector could be potentially tapped for improving the efficiency of private sector disease control program. Some of the well-documented ones start from TB or HIV or STIs or ARIs or polios or malarias, etc. On the other hand, you also have a global PPPs, which are in the form of global fund, etc. But engaging the private sector is not a very easy task. As if some of us tend to believe that the private sector is there waiting for us waiting for the government funds, and they would like to come on board as quickly as possible. Private sector engagement has its own complexities, and those are the complexities that I am trying to focus upon. Number one, private sector is not a homogeneous group. It's not about all the corporate hospitals or the private sector. A predominant force of almost 80% to more than 80% of the private sector in India, the formal private sector, when I use the word formal, I meant allopathic doctors. They're all individual owner-operated enterprises. But the problem of engaging the individual owner enterprises is that governments always have tendering clauses. The tendering clauses makes the government to put together some kind of eligibility conditions. In eligibility conditions, you invariably rule out some people who do not have public health experience or experience of working in this disease control or that control program. You need to have some kind of an asset, you need to have some kind of a turnover, you need to have some bed strength, you need to have some human resource minimum capacity in order to bid for any kind of a government contract. So there is a problem of looking at the private sector and defining whether they are contractable. The second problem is a large group of informal providers. Do you ban them? Do you mainstream them? Do you use them? What's the incentive for them to really come on board? The incentive that the government is trying to provide is more than what they can earn for themselves? That's a big question. And the third and the most important one is that there is a huge distrust between government and the private sector. Government always has presumed that they are the sole responsible, mandated people to provide health services. And if they fail, no one else should be providing. If that is the kind of an attitude within the government, obviously you will have a great deal of distrust about who else provides. They may not be as good as. But there is another interesting facet about the private sector in India. A large proportion of private sector people are actually those who are moonlighters from the government. Last year I was part of one of the missions, review missions. We were into one of the cities where a famous medical college. And the medical college professor tells the TB patients that if you take the government supplied drug, you will die. I am writing here the prescription and go and buy it. This is a medical college run by government, and a professor from that medical college makes this comment. So you can jolly well imagine whether private sector and the public sector, are they very distinct people in terms of their behavior? The next one is in terms of suspicion of each other's motive. Private sector suspects a great deal that the government wants to have a foothold in their door and will trouble us to no end. They wouldn't like us to even take a contract and then send an income tax officer to find out how much did I earn from this contract. If I made some errors in my auditing, the government will send a vigilance person to or blacklist me, and I will have my reputation sullied. So there are possible problems within that. And of course, we know and we heard several times that there is a regulatory problem. What's the perception of each other? I mentioned about perception. Both of them don't trust each other. The private sector is always viewed as of variable quality. They don't have accreditation. They are not regulated. They often indulge in inaccurate diagnosis or delayed diagnosis. They have an irrational treatment behavior. They retain patients till they come to a stage where they cannot pay up, and there is an exploitative nature. In many Asian countries, we have a cultural stereotype about the word profit and the word private. And these stereotypes is cultural. It's somewhere subconscious, and it's not going to go away very fast. How is public sector viewed by the private sector? There's a great deal of delay in payments. There have been, this state, Karnataka state, is one of the perhaps pioneers in several PPP models in service delivery. There is an NGO which runs about 28 primary health centers in this particular state. At one point of time, that NGO was not paid for 13 months together. So, and you expect them to deliver the services without fail when the government does not provide the funds required. There is a risk of public auditing. There is an incompatible work culture. I say something, the same language is not shared by the government counterpart. There is a possibility that they can interfere in my hospital condition or routines. Government is not capable of professional contracting. The word professional contracting, all PPPs are professional contracts. If you decide to think about it otherwise, I don't think you should really be thinking about or talking about PPP. And whether government has a long-term commitment. Some bureaucrat comes and wants to open up a new scheme or launch a new scheme, and the bureaucrat gets transferred after 3 years. A new bureaucrat comes and wants to have his own say in the entire scheme. Very often schemes fail because new bureaucrats did not want his earlier predecessor's scheme to continue. Where is the long-term commitment of the government? Neither the politician nor the bureaucrats seem to say that private sector engagement is going to be a sustainable policy for the government. And there is, we know that there is a huge proportion of private sector in this country. But not a single state government in India has a dedicated cell or a wing or a department or a division to handle the private sector. And there you have, on the one side, you have allowed it to grow, and now you don't even want to acknowledge that. Whatever are the last 10 years of our own chasing up various PPPs, we found that most PPPs are just at this juncture are relationships or contracts of good faith. So some leader from the private sector, somebody from the public sector got together, they thought that let's do something good. There is no institutional guarantee, there is no policy guarantee. Except for one state, rest of the country does not have a PPP policy for the health department. So I mentioned about senior bureaucrats are very enthusiastic, but lower officials suspect that they will lose their job, or PPP is an indirect privatization or selling of government silver. A lot of PPPs currently are input-based contract, that L1, that lowest bidder should be the people to be taken for that. What are the demotivators for private sector? I am running out of time, therefore I will be a little faster on this. Low patient volume in disease control programs. Inadequate incentives. Is the incentives more than them retaining the patients and treating themselves? Can government provide more incentives than what they can themselves be capable of earning? There is an inflexibility about the drug regimen, either dots or nothing else. Whereas private sector are known to provide a variety of regimens. You cannot really publicize that I am treating HIV patients and TB patients. In several Asian contexts, these are stigmatized diseases. Therefore, a private sector trying to say that we are treating HIV patients will make other patients not to come to that particular facility. They also have a kickbacks being lost. If you provide them, or if dot center is the next door to really send the patient, they tend to lose their kickbacks or commissions. They also need to really comply with a lot of unforeseeable regulatory conditions. For example, recently TB had this notification of any kind of diseases that have been positives to be detected. But nobody really wants to acknowledge even that notice. In terms of training, there is a regimented one. A lot of people do not really want to go and attend a training program in government which is held somewhere in a corner, and not many of them are coming forward to attend that. So there is another possible problem in this case is about PPM and PPP. Under PPM, you have a lot of confusion about what's the role between the private sector and the public sector. You do diagnostic here and then do what? You do dots here and then who diagnoses us? So that kind of a mix-up has really led to a great deal of confusion about the role between each other. And then finally, I am using this particular phrase because if any of the disease control people are here, they are generally called as mafias, disease control mafias. I mean, if you don't believe me, please go and talk to some people. The reason is that they always look at it in a very silo or a very, very, narrow angle of themselves. Oh, that's a NACO problem. It's not RNTCP problem. So there is a great deal of silos. Imagine yourself that you are growing, you are buying a grocery for your home. Somebody comes and sells oil to you. Somebody comes and sells rice to you. Somebody comes and sells, atta to you. Somebody comes and sells lentil to you. Would you not be irritated and say that, I want everything to be brought together at one place? That's why we go to mega stores, so that everything is available under one store. Why can't we think about it? You can be vertical, as the second diagram says. You can be vertical, but at least have that coordination cell. Finally, this is what we are trying to do in some of the states and also in some countries. Malawi and Nepal I work for, and in both the cases that we are trying to find out whether this is a way that we can actually implement a PPP in a long-term sustainable one. The first requirement is an institutional system. We are trying to help, even Karnataka government, we are trying to help them prepare PPP policy for the state, health department PPP policy. We are currently in the process of creating a PPP cell within the directorate and wanting to really give them inputs on capacity on contracting, templates, give them some idea about some, or handhold them for some of the contracts. Then obviously the accreditation and regulation will have to go together. So if these two do not go together, the PPP will come to a grinding halt. So it's not going to be a very smooth ride if the other systems don't come into play. Finally, I want to leave with the second phrase here. And I am borrowing this from, actually, I should have put his name, one of the famous person from TB program, Mukund Uplekar. He wrote this particular phrase saying that it's the negative perception, not negative evidence, that's a major barrier for PPP. All right, with those thoughts, I'll leave it to you. Thank you so much. My apologies because I need to leave a little early, so if there are any questions, I would be very happy to handle. But in case you don't want to really ask at this juncture, you can always write to me. I'm always willing to really respond to your emails or any kind of calls. You can always write to me at my
Thank you, Professor
Ram,
and I think you made a very important presentation, a very interesting one. I know you are in great hurry, but you tempted me to remind that in Indian television nowadays, there are always very popular soap operas, that is the mother-in-laws and daughter-in-laws. So as far as private sector and public sector is concerned, in the government side, that relationship exists, that is the reality. But you have brought out that it is possible for us to work together. And there are a lot of models which have brought out the strategies by which this is possible. I mean, in spite of the fact they may not be, the public sector and private sector may not be extremely friendly, but still we can work together. And I will give you a very simple example. With the Public Health Foundation of India, we have been able to generate one model that is called as training the private sector doctors in evidence-based diabetes management. By this time, more than 5,000 doctors have paid the fees and attended our training program. Very recently, we have started a batch and we have completed around 600 doctors, private practitioners, who paid nominal amount to come and get themselves trained for immunization practices, evidence-based immunization practices. So I'm sure it is not only that public sector or the government alone is responsible for the public health related activities. Private sector can, and they are definitely playing the role. With this, any questions, any comments? Yes, please. Yeah.
This is obviously a very political debate, but I would like to make two comments. One on the quality of the evidence, and two on the lack of counterfactual examples. And with regard to the quality of the evidence, you say, and you say it with much caution, you say that there is evidence that it can improve the efficiency, or that it can improve access, and yes, there is evidence, but there is much less evidence than many people would like us to believe. And most of the evidence available comes from small-scale pilot projects with well-controlled interventions and with a very short time horizon for the evaluation of the effects. A time horizon that is normally much too short to tell whatever of what would happen of sustainability, future evolutions, let be of contextual factors. The second remark is about the lack of counterfactual example. In the end, all this is about investing public resources in improving the efficiency of private care provision. And people have never seriously investigated what would be the result of investing the same amount of resources in improving the functioning of the public sector.
For the brevity, for this lack of time, I didn't share some of the evidence that we recently gathered. There is a report that will come out anytime soon. We did a study of comparing the public-private partnership hospitals, management contracted hospitals, along with, as against the public hospital. We found two major improvements, nothing to do with the quality, but access had improved. Number two, the efficiency is another gainer. So that report we still have to really clear, therefore there is an evidence to indicate. The third indication is that a lot of case studies that we have been doing. Last 2 years I have been involved in again rewriting some of the case studies where we chased up some of the cases which we documented way back in 2003-04. And we also added up another sample of about 70-80 patients who came to the PPP facility and tried to find out whether they spent more money coming to PPP facility in comparison to going to a government hospital and to a private hospital. In one of all the 9 case studies that we have done so far indicate that they have spent a lesser amount coming to PPP facility compared to even going to a government facility. The private sector facility, of course, was very expensive, but compared to government facility itself, coming to a PPP facility, I'm talking about rural primary care services. I'm not even talking about the tertiary care facilities. So, and you mentioned about counterfactual. Yes, there are failures, and we also know those failures, why it failed. I'll give one example of a failure in this particular state. In Karnataka, there was a tertiary care hospital which was contracted to a corporate hospital. But the contract made one mistake by guaranteeing the private hospital 3% as service charges will be reimbursed over and above their expenditure. We have been pointing out this as a mistake by the government since 2005. It's not something new. And the government had closed these particular operations last year, and they have not renewed the contract with the same provider. So there are mixed evidence. I mean, for the time's sake, I didn't really go into the details of each one of them. The evidence is being compiled, and it's not that the PPPs are really rosy, it's a path of rosy petals.
Thank you. Professor,
Thank you very much, Venkatraman. Very interesting description of the Indian scenario. I just want to make two remarks. One is that when the Government of India opened up the playground for the private sector with what you called innocuous policies, but they were actually policies that were not that, what shall I say, innocuous. They gave tremendous advantage to the private sector in terms of free land or allowing them to import equipment without excise duty, all kinds of things. But my point is, at that point in time, the private sector was not just one kind. There was a very large segment of not-for-profit institutions. Call it mission hospitals. I come from one of those, which is a non-profit institution. We charge rupees 3,000 per annum for a medical student. That's our fee even today. The point is, if the government had actually partnered with the not-for-profit, the Puttaparthi, the Amritanandamayi, the CMC, the St. John's, and there are a number of them, I think we would have created a model in this country which would have been unique for the rest of the world. I think it was a mistake that private, not-for-profit, and for-profit were clubbed together into one category. If my information is correct, some 400 mission hospitals we are serving in rural areas had to close down in the last 20 years because they could not survive in the world of competition. I think we missed a tremendous opportunity, and I think it is even now not too late to look at the not-for-profit organization, private sector. My second comment is, I think it is as late as 1976 that the European Union made a conscious decision that the quality of health care would be supervised by their public health. It's something that India must examine very closely, and one of my arguments for public health is that public health distributed throughout districts and cities can actually enforce quality even in the private sector healthcare. Thank you.
Professor John, I think this was a comment, and we
just wanted to make a comment that there are some people here who have worked for National Commission on Macroeconomics in Health. The NGO or the non-profit sector is so minuscule. Their sustainability is a big question mark. Out of the entire health establishments in India, just about 1.2% of health establishments are from the non-profit sector. And in the name of non-profit sector today, you have lots of them who are wanting the government money but do nothing. So there is this element about what exactly is a genuine non-profit sector. That question mark will really cloud the contract with the non-profit sector. The government is not in a position to really distinguish between the real ones and the ones which are for the purposes of other reasons.
Thank you. As a matter of fact, Professor John, let me assure you, if this would have been to be carried forward, this state, wonderful state of Karnataka, and my state would not have so many private medical colleges, because most of them are owned by these decision makers, politicians. If they were to have these non-profit making bodies, where will they make this money to run their own empires? I mean, it's a pathetic situation that these fellows who require to be blasted as much as possible go on talking on one platform something different and actually practice in a reverse direction. So anyway, this country has this dichotomous situation so fantastic that all these decision makers, they design the policies in such a way that it will benefit them. Otherwise, why these 400 mission hospitals should have been closed down? And why so many private hospitals are getting literally these, without naming, I can tell you, there are private hospitals who, in consultation with the government, ensure that government is cheated. this is the reality. We have seen that. I have witnessed one of them. Anyway, leave aside. I don't want to spell more on that. The point that I'm trying to make is that public-private sector has a role in this country. This is one sector which is totally unregulated. One very positive step that government did was to pass the Clinical Establishment Act. And this Clinical Establishment Act, which was passed, is now pending in the most of the state government, and I can clearly indicate that the different medical or professional associations are ensuring that it is blocked. No state is implementing that. Why? Because the moment you allow those rules to be cleared, the private sector will come under control. That's what their fear is. Actually, it is not, that fear need not be. So I think this is one, we don't have time, and this is one debating issue where we can go on debating and debating for days together and may not be able to come to conclusion. Anyway, so what we propose to do now, and as Dr. Venkatraman has to leave, the suggestion has come that we will now break for a cup of tea, but before that there will be one announcement and assemble back within 10 minutes to carry forward our further discussions and further presentations. Thank you.
Yeah, thank you. And I'll take this opportunity to thank Professor Venkatraman. He had to leave early, and so please accept a token of appreciation for sharing your insights with us. Thank you very much. So tea is ready outside, and we shall hopefully resume the session within 10 minutes. Thank you.
Just all of you to please come back within 10 minutes so that we try to finish in time. If you so desire to continue up to 7 o'clock, I am very happy to do that. Thank you.